Thank you, everybody, for joining. My name is Eric Bailey. I am the manager for the Alliance for Addiction Payment Reform. I work here at Third Horizon alongside several of my colleagues who are joining the call today, including Greg Williams, who will be one of the featured panelists on today's call. Again, happy to have you all here. A couple of housekeeping things. Robert and myself posted some links to the white paper that we'll be discussing in the chat, so feel free to grab one of those versions. They're the same paper, just different sources. Please let us know if you have any issues accessing that or if you're having a hard time downloading it. Please reach out to me directly. I'm happy to help out. Also, as you have questions as we're going along, please feel free to pop those in the chat. I'll be monitoring that as we go along, and we'll make sure that I bring up questions that come up with the panelists towards the end, or I may, depending on time, invite folks to unmute themselves and go ahead and ask the questions themselves. So we will make sure that we have ample opportunity to do that towards the end of the call for today. If you have not already taken a peek at the agenda, you can do that by going to incentivizerecovery.org, and I'll go ahead and pop that link into the chat in a moment. But you can go ahead and add that or go to the meetings link in incentivizerecovery.org and then navigate to the meeting agenda, and then you'll be able to see our run of show today. With that, I'd like to go ahead and introduce today's topic. We'll be spending the majority of today's call talking about the release of a paper that was actually just released today publicly, which conducts a review of peer recovery support services value proposition papers. There are a number of folks who are involved in authoring this particular white paper, and we have several of them on today's call, and then others who have been supportive of these efforts along the way. So I will go ahead and introduce the panel in about 15 minutes or so. But before we do that, we want to make sure that there is an opportunity to kind of just go through some of the basic framework of what is covered in the white paper and what we've uncovered. And Lindsay Reeves, who is a director at Third Horizon and is on today's call, has graciously agreed to run us through a quick deck on that so we can use the front half of today's meeting doing that. So at about probably 20 after or so, I'll pick up the baton again and introduce the panel, and then we'll get going with that. Lindsay, I'm going to go ahead and see if I can find the document here, share my screen. Just give me one moment. Okay. And let me do a quick, make this look a little better. All right, Lindsay, why don't you go ahead and kick us off, and we'll go ahead and get started.
Awesome. Thank you so much, Eric. And hello, everyone. It's great to be with you this afternoon. As Eric said, my name is Lindsay Reeves, and I have the honor of serving as a director here at Third Horizon. And today I have the distinct pleasure of walking you through the findings from a white paper that we developed with Unity Recovery on the value of peer recovery support services when delivered through community-based organizations. We can go to the next slide. So as has been mentioned today, that we have released a report entitled The Value Proposition for Peer Recovery Support Services Delivered Through Community-Based Organizations. This report highlights the importance of PRSS being delivered in community-based organizations and how it significantly improves individual recovery capital and contributes to better health outcomes in health and social determinants. For the purposes of this paper, community-based organizations are defined as peer-run and community-rooted organizations that deliver recovery support services outside of clinical settings, often staffed and led by individuals with lived experience. They provide holistic, culturally sensitive, and flexible care that addresses social drivers of health and strengthens recovery capital. Our goal with this paper was to really understand the current state of PRSS funding and propose actionable recommendations that would enable community-based organizations and recovery community organizations in particular to sustainably scale services that are proven to work. This work is more timely than ever, given rising cost pressures in Medicaid managed care, broad health care cuts, and the need for scalable, sustainable approaches that believe in and invest in recovery supports. Next slide, please. As we've mentioned, CBOs are uniquely equipped to deliver peer recovery support services effectively. They're rooted in community, often peer run, and they operate outside of traditional clinical hierarchies. This allows them to provide support that's culturally relevant, trauma informed, and deeply trusted. Next slide, please. And peer recovery support services offered in community-based organizations really address more than just substance use. They support housing, employment, harm reduction, and recovery capital, like we've talked about before. These services meet people where they are. They build stability across multiple life domains, and that is the true value of community-rooted care. As you can see on this slide, we've also identified some of the impacts that community-based organizations employ or empower within their communities, including better recovery outcomes and ultimately creating stronger communities. Next slide, please. We also know that there are some major challenges in funding related to providing peer recovery support services in community-based settings. Historically, those services have relied heavily on grants, which are great for innovation, but not sustainable long-term. They're short-term funds usually. They require a lot of administrative burden, and they often don't allow for the full scope of services that community-based organizations provide. Many of the organizations most effective in reaching marginalized populations are also the least able to access this type of funding. To delve into that just a little bit deeper, if we go to the next slide, within the report, you will see that we referenced SAMHSA's a 2023 national report from SAMHSA that confirmed that discretionary grants make up over a third of recovery support services funding, and organizations serving marginalized communities, again, face the highest administrative and eligibility burdens and barriers. And so when we think about that paired with the limited reimbursement from third-party payers, the complexity that is federal grants, and the administrative burden, we really see that CBOs need more stable, flexible funding models to scale peer recovery support services and really maintain that long-term impact. If we can go to the next slide, we also know that there is a lot of work currently happening within Medicaid and private insurance as it relates to reimbursement for peer recovery support services. We know that 49 states now allow some sort of Medicaid reimbursement for peer recovery support services, but the details matter here. Reimbursement rates, certification requirements, and supervision models vary widely among those 49 states. Some states require clinical supervision, which excludes many peer-run CBOs unless policy shifts happen. The next slide will show that while this is beautiful to see that 49 states offer Medicaid reimbursement for peer recovery support services, what we can see is that reimbursement rates range drastically from about $7 to $24 per 15 minutes for one-on-one services. And there's even more variation for group peer recovery support services. When you dig into the white paper, you will see that we dive into 4 states in specific and build out kind of case studies related to those 4 states. Today, I want to highlight 2 very contrasting examples. So if we go to the next slide, the first state that I would like to highlight is Texas. Oops. Yep, sorry. Okay, so the first state that I want to highlight is Texas. Their reimbursement rate, you are correct, is slightly higher than Pennsylvania, but where we see the drastic difference in Texas, while peer recovery support services are reimbursable, they are only reimbursable if they are provided under clinical supervision or embedded within a facility. Recovery community organizations cannot currently enroll as providers in the state of Texas. And while legislative changes could open the door to this opportunity, more investment is really needed to make that a reality. In contrast, if we go to the next slide, we note that New Hampshire has a pretty different approach. So New Hampshire offers a specific provider type for peer programs. This enables credentialed peer workers to bill Medicaid directly when supervised appropriately. This model is worth watching as it demonstrates how regulation can unlock access to sustainable funding. If we go to the next slide, this is where we really get into the key components of the white paper. Based off of all of our data gathering and review, we've identified 5 key recommendations that would allow the peer recovery support services sector to really strengthen and scale within community-based organizations. They are grounded in what CBOs are already doing well, but what the policy and payment systems need to do differently to support their ongoing success. So first of all, if we go to the next slide, the first piece that we looked at is really strengthening the peer workforce. We understand that there are several different, or there's varying levels of certification standards across different states. Our paper recommends that there becomes uniform national certification standards, creating consistent certification for peer support specialists across states, promoting reciprocity, and really enhancing career mobility for that workforce. The other pieces that we look at related to the peer workforce include training and career development, where we recommend investing in ongoing education and training program to build skills, and then peer-led supervision models. We recognize the guidance that was released by CMS earlier this year related to supervision, but we also recommend in the paper advocating for peers with significant experience to serve as supervisors, creating that peer-led leadership structure within CBOs. If we go to the next slide, our next piece is really looking at investing in technology and infrastructure. And so within this, there are 2 main recommendations or components that we delve into within the paper. The first one is the adoption of electronic recovery records, which looks at providing funding and technical supports for CBOs to adopt ERRs and other digital tools to enhance service tracking and outcome reporting. And then the second piece of this is really leveraging any available federal technology incentives, such as enhanced Medicaid matching funds or behavioral health infrastructure and technology investments to encourage CBOs to invest in data sharing technology to coordinate with healthcare providers, schools, and criminal justice systems. If we go to the next slide, the next group of recommendations that we explore in the paper really focus on fostering collaboration with health systems. And so the first piece of this looks at partnerships with hospitals and behavioral health clinics, where we are looking at encouraging hospitals, clinics, and CCBHC's certified community behavioral health clinics to integrate peer recovery support services into their care models using designated collaborating organizations to allow CBOs to provide those services in partnership with larger health systems. And then integrating care models to really promote the inclusion of PRSS in integrated care models, such as accountable care organizations or addiction recovery medical homes to really streamline that recovery care across settings. Our next recommendation bucket looks at expansion of third-party reimbursement. And so this looks at standardizing reimbursement rates across states to advocate for wider adoption of peer recovery support services as reimbursable services by Medicaid, Medicare, and private insurers, expanding state policies to ensure both mental health and substance use disorder services are covered under third-party payers, and standardizing reimbursement rates across states. As you'll see in the paper, there is drastic variability between the reimbursement rates across states. And so we look at ensuring that equity and consistency in peer recovery support services funding. And then finally, the final recommendation that we really delve into is developing alternative payment models. This looks at bundled payments, quality-based incentives, and value-based contracts and shared savings to fund the expansion of peer recovery support services, allowing those community-based organizations to build out flexibility in service delivery, capture savings generated from improving health outcomes, and incentivizing for quality-based returns. And this I know is very quick and very high level, but I definitely look forward to being able to delve into this further with the panel discussion that is coming. But thank you so much for the time and the opportunity today.
Thanks so much, Lindsay. And I know everyone that was a super quick overview, but definitely hit the key highlights that are outlined in the paper. So without further ado, I'd like to go ahead and introduce our panel for today to further our discussion. So panelists include Robert Ashford, who is a PhD, MSW, and the Executive Director of Unity Recovery in both Pennsylvania and Texas. We have Cheryl Acapelli, who is Project Director, Peer Recovery Supports Facilitating Organization Harbor Care in the state of New Hampshire. Susan Nayamura, who is President and CEO with the South Florida Wellness Network. And then Greg Williams, who is the president here at Third Horizon. So I think what I'd like to do, I will go ahead and ask questions of each panelist individually to start with, and then we'll open it up for some broader questions. And in that process, panelists, if there's anything else that you think is important for the group to know about your organization, feel free to mention that as we're rolling through. Greg, I think I'd like to start with you. Can you talk a little bit about how community-based organizations and recovery community organizations should be framing up their value opportunity to payer organizations?
Yeah, thank you, Eric, and thanks, Lindsay, for overviewing and everybody for jumping on today. I think first and foremost, I'm a person in recovery and grew up in the era of hearing the words recovery-oriented system of care, probably 20 years ago now, for the first time, and really hardening on this notion of how misaligned and perverse our system is. In my own story, I was blessed to receive professional treatment at age 17. And that quite literally in my 20 plus year journey was the only investment the healthcare system ever made in me for the chronic illness that I have, right? And there was no structured peer support. There was no, for me, recovery education opportunities. I was fortunate enough to receive some recovery housing, which was immensely helpful. But I think what we've learned and what we know is that we can invest all the money we want in evidence-based treatment and care and even early intervention or harm reduction strategies. But if we aren't developing and building a system aligned with the chronic disease that substance use and mental health challenges are, we're not building the system that is most effective. And in order to support people either in lieu of professional treatment or after professional treatment, if they need it, we need to have organizations in people's communities where people live, where people can go to develop and support their recovery. And so I think RCOs or recovery community organizations, CBOs that provide that support have been so beneficial for communities that have them. There's so many communities that don't have them. And I think part of the challenge historically is that we funded them through federal pass-through block grants and state funds, which, as everyone can realize on this call today, we're at a moment where that's challenging to sustain funding through those streams alone. And most importantly, we haven't scaled many of the programs that were around 20 years ago when I first started are the same size, or they have the same level of infrastructure or staff, or they've gotten smaller, or they aren't around anymore. And so the sustainability and scale to meet the need, we just haven't met the moment with existing funding streams. And so I think part of your question, Eric, is we are at this moment of inflection where historical funding is at risk. The value and the evidence is clear, and the level of scale required is something that is so much bigger than what we've done historically in the peer recovery support movement. And the challenges are fraught when we develop peers. We'll get into this, but when we develop peers outside of community-based organizations or RCOs. And so we'll dig into that more. But thanks, Eric, for leading us, and look forward to the conversation.
Yeah, thanks, Greg. Susan, next question's for you. When you and I first connected about a month ago, you mentioned experiencing differences in receptivity to recovery community organizations despite servicing a relatively condensed geographic area. So a couple of counties that you and I talked about. Can you talk a little bit more about how that dynamic has impacted your operation and whether or not it's impacted your ability to secure a sustainable funding?
Yeah, thank you so much, Eric, and thank you for the conversation. Well, this is something that hits really close to home on a regular basis, even despite the current political climate now. But yes, there's definitely some challenges. We're venturing off in Florida. Florida is a very different state as but geographically, it's also very different within the state. And so I live in the southern region of Florida where things are a little bit more innovative and a little bit more receptive. And then you go a little bit further south and call it red, you can call it blue, you can call it whatever color you want it to be, but you can see that there is definitely a heightened change in the perception of recovery support services and the value that it actually brings to the community. And also being part of the statewide RCO and venturing into other counties, the way they view recovery support services as being an added value, but not really compensating it as an added value, nor seeing the benefits of what it's doing within the community it's really disheartening, but it's more infuriating than anything else, because we know, as you said, Greg, the research is there. We already know what's coming out. We know what they want us to do, but they don't want to pay for it. And they don't understand that paying for it means that you're bringing this value into the community, which means the possibility of people that are struggling with these acute health issues are going to have an opportunity to live successful lives and contribute to the community that we're trying to serve. And I think that's what we're seeing across the state of Florida, that it is the equity is beyond. And the way the funding comes down, all comes down to money, as we all know that. And that's the difference between substance use and mental health dollars and where the money lies. But even separate and apart from that, it also depends on what color your community is. And that is a big proponent that we're seeing across the state of Florida, that we're really trying to navigate and really educate upon, because people are dying. And we know that they may think the numbers are going down, and as we're continuing to see, they may be over here, but they're not really. And I think that's where we need to keep raising and elevating voices across our communities and educating people so that they understand that this is not about us settling for the crumbs, but it's really about us advocating for the dollars that need to be put in healthcare.
Thank you very much, Susan. Very well stated. So next question I have, Cheryl, is for you. Harbor Care has played a unique role amongst RCOs operating in the state of New Hampshire. Could you take a few moments and describe Harbor Care's role and how it's been an asset to the RCOs in the state of New Hampshire?
Oh, yeah. How much time do we have here, Eric? So, Harbor Care is a primarily housing, healthcare, and veteran service organization, nonprofit in Nashua, New Hampshire. One of the biggest in the state. We have maybe 300 employees. So, New Hampshire is small, right? We only have 1 million people that live here. In 2016, an RFP came out to survey and begin building a recovery community network in New Hampshire, to which Harbor Care won the proposal. And what they wrote is that they would be like a backbone organization for all the RCOs that wanted to be developed, because at the time, there was no recovery community centers, no peer supports in New Hampshire at all. And unfortunately, the time was like a perfect storm. Although people in recovery knew we had an opiate epidemic going on, no one in New Hampshire was talking about it yet. They were just starting to. So Harbor Care took on this task of trying to go through the state, find out who was out there in recovery, who wanted to do this. And through that process, the state continued to fund Harbor Care. And they handed out the first 5 contracts to organizations that weren't even nonprofits yet. They didn't even own a pencil, right? They were just people in recovery wanting to help. And they handed out 5 small contracts in the end of 2016 into 17. And what Harbor Care did was everything for them, right? They did their HR, they helped with payroll, they helped them to build a board. I came on board and had some experience with training recovery coaches. And so we were doing trainings. We showed the anonymous people probably 200 times to show people this was bigger than us. Thank you, Greg. And through that effort, Harbor Care is still like the backbone organization, but now we do data management for them. We do evaluations. We still do training. I just finished training ethics for a whole bunch of recovery coaches a half an hour before this meeting. So we're still always building that network. And we also still do their invoicing. We do the credentialing for Medicaid billing. We do all that back office work that a small recovery community center can't do. And it's a la carte. So you can ask us to do anything. Some people use HR. Some people have an HR consultant. All of them use our Medicaid credentialing. The state, on their part, they appreciate the fact that they get one invoice, because now we have 21 recovery community centers, and Harbor Care has to deal with 300 pages from each recovery center, but we only submit one invoice to the state. So there's a lot of benefits administratively, as well as we're the conduit to all the directors for advocacy work, for budgets, for things like that. I just touched the surface on what we do, but it has been a model that has been extremely successful for building a network. And because of it, we joined Robert, I don't know, maybe 5 years ago, maybe, and with Recovery Link. And currently, the recovery community centers in New Hampshire are the only people in the state of New Hampshire that have data that is accurate, consistent, and quality. No one, treatment doesn't collect data the same way. We There's 21 of us. We all do it the same way. And because of that, we'll talk about later what that has given us. So I don't want to
Yeah,
spoil.
thank you. Yeah, Cheryl, that was amazing. Robert, last question is for you, and then we'll roll over to some questions from folks that are attending the meeting today. But Robert, Unity Recovery operates in 2 states and distinct urban areas. What are some of the differences you've experienced in the geographies that you serve, and how have you leveraged the differences to improve service delivery?
Thanks, Eric. And shout out and special thanks to you, Eric, and the Third Horizon team and Greg for both partnering us on the underlying white paper, but also just continuing to push forward the idea of innovative and alternative financing models for this field, both peer services and beyond, but also the continued connection to this work and recovery support services. And for those, I know many of you just looking at the names on the participant list, but if we haven't met, I'm Robert, as Eric said, and we have the privilege of being the executive director of, if not the only one of the only multi-state, multi-geography RCOs. So we at Unity have recovery community centers through RCO, both in Philadelphia, Pittsburgh, Weatherford, which is outside of Fort Worth in Texas, and then most recently in San Antonio, where I'm sitting at now in a very bare office. But we just opened it. And shout out to the San Antonio team, I think grouped together in another room watching this today. I think there's 12 of them over there. Yeah, but as you can imagine, that brings a tremendous amount of unique perspective, right? Good, bad, or indifferent, or how you may feel about that in terms of RCOs operating this way. I think from my perspective in this organization, we strongly agree with Greg. There's not enough RCOs, and there's lots of ways to build community if we stay true to our peer values and the idea of what a recovery community organization or CBO in the peer space should be. And I'll start there because it's one of the reasons, as you can imagine, as I listed off those areas where our services and recovery community centers and our peers operate, they're all dramatically different, right? Not just state to state. Pennsylvania, even if the middle part of it is Pennsylvania, right? Like where we operate on the very corners of the state is very different than Texas, certainly, right? Because both Jason Howell's on the call, and shout out to recovery people and the great work they're doing, but they're very different. And then even at a microcosm level, the counties and the local governments, even in the state, are very different. Philly is different than Pittsburgh, and rural Weatherford is very different than San Antonio, Texas. But even with those differences, which I'll come back to in a moment, one of the great things about fidelity to the peer model is RCOs operate with local champions, local people in recovery, peer specialists. So regardless, very similar to Cheryl, though Unity certainly leverages its resources and scale, providing administrative infrastructure and certainly best practices and lots of experience in how we deliver peer services, we have hyper-local teams that represent that community, that live there, that work there, like our San Antonio team in the other office. And it's the differences and variation between hyperlocality, states, regions. That is one of the best ways to maintain fidelity to the model. And I think if anybody tries to accomplish that, which I think we're all going to have to at certain elements that operate large enough organizations, because the scale is almost insurmountable to Greg's point, right? I think maybe there's 250 RCOs, probably another 750 if you include the mental health kind of community and day centers on their side, which are very similar and should be included in this conversation. They are RCOs as well, or we're all peer-based organizations. But one of the things that's unique that I want to make sure not to forget on is there are differences, right? And there's 2 case studies in the paper of the differences in how Medicaid reimbursement and other funding streams in Texas and Pennsylvania are, right? And navigating those, I have found beneficial when we do have centralized administrative resources, right? It's why national organizations are helpful. We can look at and support local teams, both in state capitals or state houses or at the federal level, and certainly with administrative infrastructure like creatively funding through block grants, private foundations, opiate settlement dollars, right? You'd be able to streamline all of those operations because the truth is they are all dramatically different, right? And I think one of the things, though, that I will end with is the question was positioned on how they're different. How do you navigate that? We're also in a unique position to say, where are things the same, right? Where do we start seeing consistent barriers and are likely to manifest with our colleague organizations and other peer organizations in other states, other localities? And I think a lot of the recommendations we make in the paper, we see as consistent, right? And if they're consistent across Texas and Pennsylvania, I think we would see these in a lot of areas. And it is some of those big ones, right? Of how peers are actually integrated into the system of care. How are supervision is thought of? If they're a bolt-on and afterthought, is there meaningful investment and innovation? Do we see them, to Greg's point, actually growing since the mid-2000s after the rush in the early 2000s when we kicked off? And then the answer is no. So we don't have strong legislation, though there is certainly movement in Texas. Jason and recovery people and some partner organizations are leading a great bill similar to what we're looking at in Pennsylvania and trying to find the right language to ameliorate some of those consistent concerns, right? So I do think, in summary, if we're thinking of doing this, or what do we actually, as we look at not just for national standards for the certification of peers, if we're looking at RCO's replication and meeting the call, as Greg put it, to the size and scale of services we would need if these do get covered, those are going to have to be addressed, right? We need to look at some of those big ones, which again, for us is supervision, how legislation is written, some credentialing these services, because I think the biggest misstep and the thing that we've seen consistently, but more perhaps in Pennsylvania, but I think it's everywhere. And the paper highlights that is, if peer organizations can't stand alone, I don't care if I have access to medical assistance or any other funding source through a CBHC or an FQHC or some other organization, if I can't enroll and control our own organization as a peers, then we still haven't met the call to action 2001 in St. Paul and Minneapolis, right? If peer organizations aren't standalone, then that's not good enough. And so while we have maybe ways to get there, I think that's what we've seen strongest consistently, and it's pushed the passion behind Unity as we look towards scale and growth in the next evolution. We want to partner with everybody, but until we have control of that sustainable funding stream where we are masters of our own fate, as it were.
No, thank you, Robert. So the good news is we've got ample time for Q&A, and I think what I'd like to do, because some folks may have to drop at the top of the hour, I'm going to go ahead and start with some a couple audience questions that have come in through the chat. So this is directed to the panelists, and we don't need to go in any particular order. And if you've got something that you can contribute to this question, that would be great. The question comes from Jason Howell, and Jason, thanks for joining today's call. So Jason's question is how do we customize value propositions that speak to different political perspectives? Aligning with one party and not the other sets us up for inconsistent funding. So I know, Robert, you had provided a response in the chat. You're certainly welcome to chime in, and others as well.
Oh, I know what I said in the chat. It's the pragmatic reality, right? I'm not a radical change agent, regardless of what social media may look like. I'm a pragmatist, right? How do we get the most things done? And it's often through incremental change. But there's two sides to this, right? There is certainly the advocacy side, where a lot of these talking points will be certainly more salient, more important. I agree with Jason that our own internal community, I'm also guilty of this because I have very deeply held beliefs, especially as they might stigmatize or potentially harm my friends in my community. But we do have to do better at that, especially the advocates of meeting people. Jordan said where their beliefs are. I agree with that. However, I would also say that the type of things that we're talking about, advocacy alone will always be less effective than actual lobbying will be. And lobbyists don't necessarily have this issue of meeting people where they're at, they're getting paid to do this. So I think we have to consider, just like we did with the recovery support set aside, and we capital decisions. Everybody, I think, knows Carol McDade and Greg and even y'all's work, right? We've got to consider both sides. And that issue is very important on the advocacy side. And we do have to contend with this. But we also have to make sure that we are including all things to make political change, which means we need, especially RCOs, other peer-based organizations that are larger. Our Unity would certainly be one of those. I think both of our panelists as well. I saw Jen King from the Southeast Council and ProAct on the call, right? Like we have to put some of our resources back there to lift all boats, because advocacy alone is not going to make the type of change that we really want. I know that's a slightly different answer, but mainly saying that I agree with you. I'm not sure how to do that because I'm not always the best at it, Jason, but I also want to make sure that we're not just squarely focused on advocacy, because we've got to do more. Because I think we've never contended well with our resources in lobbying compared to our colleagues in treatment and prevention, for example, and they often win out in some of those conversations.
I mean, I'll just chime in. I think one of the reasons that I focus on payment and finance today is I was squarely in the advocacy world 6-7 years ago and had the instance to meet our CEO's former partner, Governor Mike Leavitt, who was the governor of Utah and the secretary of HHS under President Bush. And I was laying out the issues of sustainable financing and the recovery-oriented system of care and the challenges that we have before us, and talking to him about there's no philanthropy, there's no resources. And he said to me, the bottom line is this is 20% of our GDP, American healthcare. It's $4+ trillion, closing in on $5 trillion. There's plenty of money. There's plenty of money. It's just the economically invested dollar is going to go 100 times further than the philanthropically invested dollar. And I think what we haven't done a good job, and we're starting to get there, is really articulating that value proposition, which certainly appeals to potentially one political affinity more so than another, perhaps, depending on the state. But with Medicaid cuts coming, like economically invested dollars is going to be relevant to either party or an independent party, whatever happens in America, or your state. But this idea that there's going to be a lot of downstream pressure on Medicaid and other public financing, given where the state of our economics are in this country, peer recovery services, even if we get all the money we need, like it's still the cheaper option. Like it is still the most economically valuable thing we can do in the substance use continuum. When Medicaid directors are sitting there staring at claims data that show tens of thousands of dollars being spent on individuals every year in redundant recurrent care, in emergency care, in inefficient care, and mapping those patient journeys, mapping that spend. And so it isn't really about going to state legislatures and going to Congress and saying we need more money. It's about saying, hey, peer recovery support services is a better way to spend our money. Let's see what we can do more efficiently if we invest over here and think about that. Now, we'll get to this probably soon, but like we have to structure those payments so it makes sense for CBOs. But I would just say that some of this is economics, and we have to get better at telling the economic story of the value that peer recovery offers in contrast to our existing status quo.
So Greg, I just want to add to that. I think you're 100% right in having people understand the cost effectiveness of this and cost savings of peer recovery supports. And through another thing Robert got me involved in, I met a recovery scientist, Sandra DiMartel, who has a cost calculator that you can put your data into for peer recovery support services. And we were able to use that to show the state of New Hampshire how effective the services were compared to other things they paid for in the state. And that made a huge impact on us. Like we actually, it's hard for me to say on this call, we got a 10% increase in our budget this year because of that data that we were able to present. No recovery coach ever said they want to do data, but we have to get them to do data because it is so important.
Yeah, thanks for that, Cheryl. Susan, anything that you'd want to add on that question?
I do actually, because this is a really interesting conversation. And obviously, Robert has a tremendous impact across the nation because data has been driven, even in our minds, in the work that we do. And for a very long time, the work that I've been doing has been very local up until maybe the last 4 or 5 years. And then I started doing a lot more statewide work and getting more actively involved. And it's interesting because I see 36 people on this when I feel like there should be hundreds of people in this meeting, because I think that number one, there's strength in numbers, and without accurate information and understanding of where this could be going or where it should be going, we're going to continue to keep fighting over crumbs in our local communities. And that's what I often see happening in community-based orgs with peers or recovery community organizations. And I think there's so much value that's taking place here that a lot of people are going to miss, but we're going to share those recordings. But I think that all in all, data is one of the things that we have even found, because now we have the state saying, can we have your data, right, Robert? And law enforcement, can we have your data? Because they recognize that they need that data, and they're seeing the work that we're doing. But not only do they see the work, they're seeing the impact, and they're recognizing that it's costing them a fraction of what they're paying now, and they don't have a return on investment because they don't have the lives, because they're still seeing the numbers rise when you get their ODQA heat map and all of these things happening, and they want to know what we're doing different. What are we collecting that's making a difference in people's lives? Cheryl, to your point, I think it's so important that we're sharing this information, but also really putting it forward and really making sure that we're not diminishing the work of the peer worker and the value of it, because I think that's another thing that's happening now, especially as we're seeing the struggles within maybe budgets or things that are taking place, because people are taking lesser on the dollar because they think that it's going to make a difference, but it's not. And so my hope is that this recording does reach far and wide, so people have an understanding. They need to go to hear the credible sources and not just take things at face value.
Yeah, thank you, Susan. And Joe, I see you got your hand up. I'll come to you in just one moment. I want to make sure I get to a question that came in the chat because it actually dovetails very nicely with everything we've just been talking about. But Jordan brought up striking that balance between retaining that autonomy as an RCO and then recognizing that there's an importance for diversification of funding, and whether that's coming through philanthropy or Medicaid, and then recognizing that there's some things to take into consideration. So the question really is, how do we build up that sustainable system while remaining true to peer support's roots as a liberation movement, in Jordan's words?
I raised my hand, but I did. But I'm happy to go first because Jordan and I we talk about this quite a bit, right? And it's important. The recent work that we did with our piece of legislation in Pennsylvania, as we heard from other peer orgs and CBOs, right? And this is a common thing, right? And I think it's even more ever present now with the kind of current state of federal play with potential cuts to CMS and the impact of state budgets, the big beautiful bill, all this thing, right? Because even on the sustainability portion, will these dollars even been there? But I think two things are true as we've both done this work, and to the larger question. One, peer organizations have to have choice, right? Like the idea that we need to create infrastructure, regulatory burden to get this type of unlocked funding in the ways that we might want it should not mean that every community-based organization, every RCO should have to meet those standards if they don't want to go after those dollars, right? I think that we want to maintain that fidelity to some of the community-based model, but the option should be there. I think that's point one, so that you can choose the devil you want to be with, as it were. I think to Jordan's point, because there is trade-offs. It's an incredibly true statement. And I think there's always going to be an element that is any successful business, because an RCO is an organization, nonprofit or otherwise, hopefully they're nonprofit, right? But it is a business and has to be run. Braided funding streams is always going to have to be the truth of the matter. But it's much easier to braid funding streams when you have one of the biggest potential funders of those services. So I think it's incumbent upon every leadership infrastructure of CBOs that are going to potentially do this, advocate for it, is know what that looks like. Historically, RCOs don't have braided infrastructure in the administrative side because we haven't even potentially touched on it. But could most RCOs even bill medical assistance or commercial insurance if they wanted to today? People on recovery link certainly could, right? But not most RCOs aren't using electronic recovery records. I think everybody has to choose and get ready for it and follow the recommendations in the white paper, perhaps to meet there. But I think it's that braided funding stream mix that will have to be mixed in the right way for that organization. The other big point, though, and it's certainly mentioned, and I think Third Horizon does, and the Alliance, everybody here for other reasons, that the work that you've done with addiction home healthcare, finding an APM for peer services, be it capitated payments, population health, because setting as a service in RCOs matters. What's happening in the community center that's not necessarily a traditional billable unit. All of that matters. I'm not particularly interested in billing at a per unit basis and chasing those and floundering in it as an RCO because it doesn't model the type of work we do. If it takes 30 minutes to get a great recovery plan and outcome, then let's do that. But then we should be paid for the outcome, right? So some combination of value-based contracting, alternative payment models, capitated payments, like that's what we really want to be looking at. But as the incremental thing that I talked about before, we've got to get there. The first step in my mind is we've got to unlock access, then we can go around reform. But I think that's the end place we want to be at, is with your question in mind, Jordan, is that there is trade-offs, but can we create a prophylactic against them, as it were? And I think that's through alternative payment models and value-based contracting. I think that's how we get there.
Yeah, that's the middle ground, right? It's like we can't all have our cake and eat it too. Pay us like grants, but pay us at scale to meet the need with no spigot, right? So there is some, but there is no reason that RCOs and CBOs today. CMS released some new guidance around how peers can supervise peers, and there's an evolving landscape around this. But whether it's community health workers, if it's MOUD treatment bundles, if it's Medicare monthly bundles, if it's knee surgery or maternity, the larger healthcare system is moving towards either case rates, bundles, alternative payment frameworks, because using data, as Cheryl has in New Hampshire, we actually can quantify exactly how much it costs to deliver quality, high quality, engaged services to people, knowing how the level of intensity translates over time. You build that economic case model on fee-for-service chassis largely and balance that. But the idea that we have to bill in 15-minute increments, Medicaid is probably one of the most creative. The challenges with Medicaid is a 50-state solution. The opportunity with Medicaid is that it's a 50-state solution, and it's one of the most creative, flexible funding streams that can get unlocked largely in some states. If you have managed Medicaid and expanded Medicaid, no, certainly challenges to our friends in Florida and Texas here, but for states with expanded Medicaid and Medicaid managed care, almost everybody who needs services, you actually don't even need a policy change largely to go get an APM. You can just, it's not easy, but you need to show up with the data and the right political capital. But you can go talk to a managed care entity and convince them to pay you in a different way because they're empowered to do that. It takes work, it takes creativity and strategy and breaking down the barriers. That's what we're trying to do. But I think that is the future for thinking about how to meet in the middle.
Yeah. Thanks, Cheryl. Susan, anything else that you'd like to add on that?
There's so much I want to add on that, but we're working really closely with Third Horizons on an alternative payment model up here in New Hampshire. And hopefully we'll get that through. But some of the things I think, to Jordan's point, some of those barriers of keeping that really peer-based model in your recovery center while having to bill Medicaid to try to, it's not sustainable. We have a great rate. New Hampshire has a really high rate, and it's not even close to what we would need to sustain an RCO. But some of the problems, at least in our state, is the Medicaid rules are not the same as the rules for our certifying body to get your license to do peer support services. So there's always a tension and a conflict between those two things. And so trying to balance that while keeping the peer model authentic, built from the bottom up, is always going to be a challenge, I think, but braided funding, I think Greg or maybe Robert mentioned that, is what we stand on. Our Medicaid dollars, the way they let us use them, are for anything we want, which is amazing. Most people, they take it out of your contract, everything you bill Medicaid, and they have not done that for us. So that has allowed us to grow a little, but we don't bill enough to be able to hire people or sustain a recovery center without the funding that comes through Harbor Care, which is infrastructure funding. They never have to worry with the funding through us that they can't pay the rent, the internet, the AC, the electrical. So they're able to go out and get a little grant for Department of Education or Family Services, and they build on that, build out their organization. That's all I had. Eric, thanks.
Eric, I'd probably open up a can of worms because I'm in Florida, and Florida is very complicated when it comes to Medicaid, most specifically for peer recovery supports. I've been a Medicaid provider, but I can't provide the services because of the other kind of complications, because I am a standalone peer-run organization, and it's very complicated, and we're still working through that process. But for a lot of peer workers, not to get into this realm because it will open up a whole bunch, the background screenings are a huge, tremendous issue here in the state of Florida, because we don't have just one entity that does background screenings. We have about 5, and depending upon who you're going to work for and who your funder is going to be, is going to determine whether or not you have to go through multiple layers of background screenings. And somebody like myself, I'm on my 9th exemption because we're doing employment supports through Voc Rehab, and that's another layer. So it makes it a little bit complicated for states like Florida when we're trying to diversify with some of the government funding. So it's a really interesting place, but we're navigating through it now, and we're hopeful. We do have a Medicaid designation for the state of Florida, but a lot of barriers for standalone peer-run organizations.
Thank you all for those comments. Before I get into the next chat question, Joe, did you still have a question?
Sure, thank you. I was listening and Susan asked one of my questions. I'm also from the state of Florida. I work with the Floridians for Recovery, and she's our board chair. So technically she's my boss too. And anyway, thanks for asking that question. But I think sometimes when I look at this, and I come from Pennsylvania, we started peer work in 2007, and we were Medicaid reimbursement. And I remember the billing code H0038, and everything was done through that system. And when I moved to Florida, nothing about the whole system made sense as the way anybody was employed. Was there a recovery community organization? There was no advocacy work done prior to that 2017. And as a result, the peer movement sparked off with the sewer grants in 2018. And there was this explosion of a workforce. And it almost reminds me of like football, like college football. There was free labor in the college football world for 100 years. And then 2 years ago, one of the colleges challenged that right. And now they can get paid, and they are the workforce. I don't think we leverage that component of how powerful we are. We are the workforce. And it's a lot of certifications. I think that one of the best things I heard is a national accreditation, that this is the way it's to be done throughout the 50 states. And then two, what is the wage? This is the wage that's set based on, and I'm sure there's different cost of living standards throughout the country, but it can be figured out and then it's almost like a collective bargaining agreement. All this block grant money comes out every year. In the state of Florida, we get our share, and I'm on the council, and there's no line item in the expenditure report for recovery support services, $0. And I asked the question, this will be the third year coming up in July. Where's the money attached to the expenditure? I'll tell it's bundled in there. And it's all these, like fairy tale stories that, you're supposed to believe. The people that have the power are not going to give up the power. And in the beginning, the peers were housed in RCOs and what do you call it? What CBOs, whatever you want to call it. The peers worked for recovery community organizations. Now they're co-opted throughout the system in the criminal justice, hospital care, and they're not supervised properly. They're out on an island trying to figure out how to work inside this system that assigns them tasks. And that information I got from the 2023 document. You had recommendations through this organizations about funding non-traditional peer support services, and how do we get the single state authorities to start to work with us? Okay, we're fast forward, we're 2 years from there, nothing happened there. And I don't know how to initiate that spark in our population, but we all act independently. None of us want to collaborate. And if I got mine, I'm okay. If you don't got yours, next cycle you might get a grant from SAMHSA, or as Robert said, rest in peace, you ain't getting shit from the federal government. So now what are you going to do? That's just a take for myself, being in this work for the last 10 years. And I come from the corporate America. I was a salesman and a commission salesman. So if I didn't sell, I didn't earn any money. So it's almost similar to me how this operates. Our fiscal cycle ends on Monday the 30th. We don't have contracts with our SSA, continue services, and we're in this limbo state for who knows how long. But thanks for letting me rant. I didn't intend to have it that way, but it turned out that way.
Yeah.
So
I found Joe. Oh, sorry.
No, I was just going to invite the panel to any comments, reactions.
I was just going to commiserate with Joe because we found out last week that we had funding cut, and then Connecticut PRO, which is great, but too late. Our July 1st funding rollovers from our SSA just got delayed, and they're not going to retroact like they have over the last 5 years. Due to the uncertainty, I had no solutions to that problem other than I find that shared commiseration in the current time with other peers and peer organizations helps. So for whatever that's worth, same. But I think to what you had said, I appreciate you getting on the soapbox with somebody that does it too, right? Because it's through that I think we continue to think through it. Yeah, there's lots of reasons. I think you as well know, and I've been doing this long enough, that we have internal strife and grievances that we've always had. I think even my generation has picked some of those up, though the fight may not be about MOUD or MAT now, maybe around harm reduction of this idea. All of it is tiresome. I'm sure that Joe, you have been in the field even longer. What's the next gen doing? We're just doing the same shit. And we are to some degree, right? There's been a lack of mobilization outside of a handful of times. Because I agree that we are the workforce. I also fundamentally, compared to the other workforces that are adjacent to us that tend to get not everything they want, but certainly more, right? Certainly on the clinical and medical side. I think of the actual peer workforce, right? SAMHSA says there's now over 80,000. where, right? Because there's certainly, like, outside of the 250 so RCOs that should be the employer from my perspective, right? Integration is great, but partner with a community-based organization, which I think is the same point you were making. But do we actually have is this weird workforce equivalent and as big as we think it might be? Do we have 80,000 people? Because a collective bargaining agreement would be great. We have a peer union in our Pittsburgh RCC and programs that they galvanize themselves. It's a great opportunity. Is it actually as big as we think it is? Because I know a lot more peers that can't find jobs because there's nobody hiring them. So we have an unemployed workforce, maybe. I haven't seen great data. I'm just wondering if you or any of the panelists or Greg, I know Dale's work, do we actually have a stronger understanding of how many peers are working in CBOs, RCOs, and other settings? That's accurate.
I don't know if that's accurate. The only measurement that is published out there is around the NPI piece, right? And we have a lot of mental health oriented peers who have their own NPIs, but those numbers way undercount the actual workforce. The Bureau of Labor Statistics combines peers with community health workers. There's some interesting data there. You can go on DOL's website if the database is still there. But I do want to call attention to Amy's comment in the chat around partnership. We talked about payers, we talked about states. Look, healthcare over the last 20 years has gotten very large, lots of big entities delivering a lot of different kinds of care in everybody's community. One of the largest value opportunities peer and CBO organizations provide is to large healthcare organizations, whether that be a large FQHC, a CCBHC in a community, or a large health system. In Connecticut here, the state funds this, but CCAR is providing a great value to our health systems around the state where there's peers in the emergency departments. And each hospital should be paying CCAR, and I tell the hospitals that they should be paying tens of thousands of dollars to have these peers in your hospitals because they're in at-risk contracts and the way the money flows from the healthcare system. And so that's what we do when we talk about the larger kind of integrated structure. But the idea that the hospitals don't need to hire the peers in their structure, but partner in the community in the same way that hospitals will partner with other food pantries or other kinds of transportation organizations. In the same way that happens in communities, peer RCOs and CBOs are in a powerful position to communicate a value opportunity to especially physical medicine focused organizations. Certainly the large community mental health centers and other things are maybe an easier doorway in. But I think if you haven't met with your health system CEO or health system population health manager in your community, they should be on your call list. It's not just the state, it's not just your legislators, it's not just the payer organizations in the state, but health systems now are payers too, and they see a lot of value in building community capacity to serve people over a lifespan, and they're entering these holistic contracts to take care of people over a lifespan. So having a valuable partner in the community, which could very much that could be very much like a contract structure that looks like a grant, or they have big foundations that could go raise money from big donors who write tens of millions of dollar checks to their buildings. So there's a leveraged opportunity there, and I just think we sometimes miss a direct appeal to larger healthcare entities to partner with them as contracted partners.
Yeah, thanks for that, Greg. I'm just looking at the time. We are at the end of our time allotted for the panel, but I want to give the panel opportunity. Any final words that you'd like folks to leave the call with from today?
If I could leave a final word and just to piggyback on what Greg was saying, because that's how we were able to actually expand our workforce as much as we have, because we have multiple partners with various contracts, including a CCBHC and a hospital system and the sheriff system, is don't be afraid to ask. The worst that they can do is say no. Is know the product and the service that you're offering and stand behind the best practice models of peer recovery support services, and don't bottom dollar yourself. Ask for what you need to make sure that your staff is being paid an equitable wage, and just have the conversation. I think there's a lot to be learned in conversation, and I think the best conversation to have are the ones that sometimes have a little bit of extra energy. Joe, that's all I have.
Yeah, I think closing words, and for me, is highlight again just what Cheryl said, and while it certainly can be hard to hear when a lot of us are getting cuts, right? Getting a 10% increase because you have data to show your narrative, right? To prove economics as well as outcomes. We have, to Greg's point, we've been awful at it in this field. We have relied so much upon telling our stories, lived and living experience, recovery messaging. I've done it. I still believe in it. We should do it. It's important, right? But it is the tip of the iceberg when it comes to crafting a compelling narrative to actually get funding and sustainability. So please focus on use RDP, use recovery link, use spreadsheets. Please don't use spreadsheets. Use something, right? We've got to continue to mature as a field, or we will be having this conversation in 20 years from now. And that's the larger point I would leave with is maturation of our field, right? We're coming up on almost 26 years from the RCO side of peer work, right? Of formulation, really, and again in Minnesota. A couple more decades if we include the mental health peers as we should. I'm a strong believer in that, right? But we have stalled. We've continued to grow and it's been incremental, right? But we had such passion and I think fervor, and we can't rely upon stopping that. And we're going to be having this conversation again in 40 years. Think of real infrastructure. Think about how we run our organizations. Community organizations are great, but having an FO or backbone like an FO and Cheryl, or maturating yourself like Susan and I have as our own RCOs, figure out a way to do that, because smaller 5-person peer organizations aren't going to be able to handle both the volume or the burden, our mixed payer screwed up system. Regardless if you go to the states or the commercial side, it is hard work. And that's the final thing. Part of maturation is thinking 5 years out. This stuff takes time. We've been working on the unity side and we have still failed to crack the nut of unlocking some of these in meaningful ways for years. And it will probably take another 5. Right, regardless of politics and everything else, these conversations can't come to like on the grant cycle perspective. It's not, hey, what's SAMHSA? We're not like they're not around, but what's the next grant cycle? Which is year to year is not the way to think of this. You have to think longer term and have a true strategy around it, right? And I think that's a fundamentally different, often different approach than peer organizations and other CBOs don't often have the luxury of doing. And there's also some great questions in the chat that I would encourage you to follow up with Third Horizons and connect with the panelists afterwards, since we didn't get to them. So make sure they get missed. But thank you all of the Third Horizons and EFO attending, and Susan and Cheryl for being on the panel with us as well. Love the work that y'all do. And thank you, Eric, for hosting.
Yeah, thanks, Robert. There was so much great conversation here today. And I just want to, I started in peer recovery support services in 2004. And they told me it would be 25 years. Okay. We're there now. It's 25 years almost. Next year, Greg's smiling because I met Greg when he was 18 and now he has a little gray hair. And it's here. Like for me to see all of us, even though there was only 38 of us on this call talking about what we're talking about, when we started telephone support on spreadsheets and paper, this is like freaking amazing. So don't take your foot off the gas. Like we are so close to getting this in place. And thanks to Greg and Eric and that whole team for doing that work that we can't do. We can collect the data but like Robert said, wherever you work, whatever you do, find a consistent way to collect the data, because the stories are great. They make the data even more impactful. I love the stories, but funders, they love the stories for a minute, but they want the data to prove that the work we're doing is really worth it. And we all know it. We see it every single day. Don't take your foot off the gas. And thanks to Greg and Eric and the whole team for doing the work they're doing for us in New Hampshire to try to get this APM off the ground.
Yeah, and thank you to Cheryl, Robert, and Susan for joining the conversation today, and Eric for leading it. We had a couple hundred people register, so everybody will see this. Obviously, asynchronous consumption is at its peak post-COVID on these kinds of webinars. Rest assured, this message that was shared today is going to be amplified quite far. We'll get it out on YouTube and push it out to all those who registered. In closing, I think if we do what we've always done, we'll get what we always got. And this moment calls for doing something different. And I think one really just tangible, low-hanging fruit for folks whose states aren't like yours, Cheryl, who RCOs can't bill even the fee for service, In our paper, there's a CMS new FAQ that was leveraged out of a conversation like this from, I think, 18 months ago. We had a conversation with experts in the PRS movement. They recommended CMS change this. CMS issued new guidance. If your state practice acts do not allow for clinical supervised peers or recovery community organizations to even bill Medicaid directly, it's easy to get fixed at this point. We have federal guidance that it's going to take work. It takes some work in the weeds and understanding what a state practice act, but you have a piece of paper and there's a link in the document that you can leverage. Unfortunately, we have to leverage that in all 50 states. So if anybody needs any information on how to do that, we'd be happy to provide information, specificity on how to change the regs in your state to make sure that you don't need clinical professionals to run a peer-run organization, nor bill Medicaid directly. It's obviously going to be different in each state, but I think that's one tangible takeaway that folks can do that they've never been able to do before.
Yeah, and thank you everybody for attending today's call. We did have some time set aside for Greg to run over some national policy kinds of stuff, but I think we'll suspend that for today in the interest of time. And I think rest assured, we're all grappling with a really volatile landscape when it comes to federal funding. And so, in the spirit of not creating an echo chamber, I think we'll go ahead and close things out for today. Unless, Greg, there's something specific that you'd like for the group to walk away from today's call with from a policy perspective.
No, I think just keep watching. There's two federal things to watch, right? Is the federal appropriations process and certainly the legislative process. We'll see what happens. We'll know a lot more in a couple weeks to see where that lands. But current approps process is signaling level funding for SOAR and the block grant, which is not nothing. Obviously, the White House has signaled interest in cutting it to some degree and restructuring it. Whether or not the legislative arm is going to go through with that or not, it's a big moment. So if you do have legislative relationships and you rely on any of that federal pass-through money to your state, it's definitely an important time to make yourself known, especially to the Senate side, which is digging into some of the federal approaches that'll impact your state. So just wanted to give people that piece, but thanks everybody for coming and look forward for the recording.
Yeah, and just to piggyback off what Greg said, I just want to stress the importance of advocating at the state level too. There's a lot we can do at the state and even municipal level. To use Cheryl's apt metaphor, let's not take our foot off the gas. Keep working on these issues. Reach out to one another, lean on each other. Please, for those of you that contributed to the chat, thank you very much, and feel free to reach out to me at any time for making connections or if you're having trouble downloading materials. Our next quarterly meeting will be, I believe, in September. So, which will be National Recovery Month, which is fantastic. So that'll be the Q3, and then we'll have one in December as well to round out the year. Not quite sure what we'll be covering in those meetings, but rest assured, keep your eye out. We'll let you know in advance. This recording should be available within the next couple of days. And again, thank you very much for attending today's call, and have a wonderful rest of your afternoon and week.
Thanks, everyone. Have a great evening.
Bye.
Thanks, Eric, and everybody. Bye.